Thank you all so much for joining today's Public Health Discovery Seminar Series. My name is Cassietta Trewick. I go by Cassie. I'm one of the admission counselors here at the City of Scott Weatherhead School in Public Health and Tropical Medicine. And today I have the honor of introducing one of our amazing WSPH alums, Dr. Maranda C. Ward, who is an associate professor and director of equity in the Department of Clinical Research and Leadership at the George Washington University School of Medicine and Health Sciences. Today she'll be presenting her Public Health Discovery Seminar Series titled When I Say Health Equity. We're going to have time for Q&A session. So if you want to, feel free to drop those questions in the chat or in the Q&A, in the chat, and we'll answer those questions for you. So Dr. Ward, take it away.
Thank you so much, Cassie, for the energy, for the invitation. I'm really excited to be able to present today for my alma mater, Tulane. So, as was said, I did graduate from Tulane University School of Public Health and Tropical Medicine. I was a student in the then called Community Health Sciences Department, but they now, have like a global Community Health Sciences name. And I'm here today to talk about the work that I do around health equity and really allow for us to really think about how we frame this discussion. So even though I teach undergraduate public health courses in the School of Medicine and Health Sciences, I also have a secondary appointment in our Milken Institute School of Public Health here at GW. So I'm really excited to see so many of my GW students that have logged in to basically weigh in on today's discussion. So with that, I don't have any disclosures, and we're going to jump right on in. So you're probably familiar with the fact that here in the United States, we have a health goal, health plan known as Healthy People. And so every 10 years, let me go ahead and move the bar out of the way. Let's see, how do I move this bar? Okay, here it is, the floating panels. Okay. So, as you know, I feel like most of the students that are probably logged in are public health students, but just in case you're not, we do have some commitments that we basically update every time the census comes out. So back in the 90s, we were looking ahead to the year 2000, which seemed like so far, right? But we were like, you know what? We probably want to aim to reduce disparities because we recognize disparities existed. But then we wised up because it doesn't make sense to aim to reduce disparities. Shouldn't our aim be to eliminate disparities? And then any reduction would be indication of progress, right? So by the year 2010, you see the goal had changed. Okay, let's eliminate health disparities. But then by the year 2020, the next decade, we decided, you know what? We probably don't want to just only focus on one population because, as we know, for those of us who study public health, health disparities only exist among socially disadvantaged populations. What about everybody else, right? So then we decided, okay, not only do we want to eliminate disparities amongst socially disadvantaged groups, but we want to improve everybody else's health, which means that we want to achieve health equity. We're going to put a pin in that because that's today's discussion, right? What does it mean to achieve health equity? And as you can see, the goals that we're working on, towards right now, again, same goals, but we've since added the importance of attaining health literacy, especially because, we really do live in a era of disinformation, misinformation, because, we basically have so much information at our fingertips and we really have to kind of wade through it, make sense of it all, process it so we can act upon it. And it really is a lot of, it takes skill and acumen to be able to do that. So health literacy is a really important aim. So, I know some of my students are familiar with this, so I want to hear from those who are not in my public health class. But I like to share this poll because the AAMC, if you're not familiar, the AAMC is the Association of American Medical Colleges. So this is literally the accrediting body for medical schools in this country. They did a poll and they basically asked Americans, do you support health equity? Right. And as you can see in table two, this is, you see the demographics that say they do support it or not. Right. And then they asked, do you support everyone having a fair and just opportunity to achieve their fullest health potential, which is the definition of health equity. So for those of you, again, that's not in one of my public health courses. What do you notice? Feel free to either raise your hand, mute yourself. Let's go ahead and just be informal with this. Add to the chat. Do you notice anything? Does anything stand out to you from table one to table two? You can feel free to unmute yourself, raise your hand, add to the chat. I think I should be able to see the chat, right? Right, Cassie?
Yes.
Okay. Well, let me tell you, I know what stood out to me, right? Because look, you can see these demographics. Not only do you see racial, differences and gender differences, but you also see different, differences by generation. And let's up the ante and actually show even more differences in political affiliation, class status, where you are geographically, education level, and you see time and time again, it doesn't matter what your social identity is. Time and time again, there's more support for health equity when you don't call it health equity, when you say everyone have a fair opportunity to attain their fullest health potential. I think that's really interesting, don't you? I mean, that's the definition of health equity, but given the social political climate that we live in, the concept, the phrase health equity actually has been politicized, right? It's been vilified. And so people don't support it when they actually do, right? You actually do have these values for everyone having a fair opportunity, but just because you use the phrase health equity, I'm not going to be in support of it. So I think that's very interesting in our discussion today. And I think that is also why, one of my colleagues and I, we actually authored this paper. When I say health equity, what am I talking about, right? Because right now there is no standardized way to measure or assess health equity. Depending on who you're talking to and about, you have different metrics. So for example, in France, they're actually looking at geographical differences, right? Here in the US, we're looking at racialized differences. So if you think about, here we are a part of a global community and we are all aiming to meet these sustainable development goals on eliminating poverty, achieving gender equity, addressing, climate change. Can we really try to aim for achieving health equity if we all are talking about different things? So, the World Health Organization, they define health equity, and they, as you can see, 70% of folks actually subscribe to that definition. Even the AAMC, who actually did this research, they had way more kind of those in favor of the definition, but it was CDC's definition that really kind of resonated with more and most Americans. So let's just do a quick terminology check since we're talking about terms, right? Okay. So what would you say in a moment? I'm going to show some identities and I want you, I mean, this is a very quiet crowd. As you can see, you like to have interaction. So feel free to unmute yourself, to put it into the chat. Let's have a discussion. You logged in today so that you could engage with me. So let's do it, right? When you see these identities, I want you to tell me what they have in common. Okay. So white, being a man or a male, middle class or even upper class, older, westernized, educated, heterosexual, Christian, able bodied, English speaking, American.
Hi guys. I'm trying to work on the Q&A on the chat. Drop your answers in the Q&A chat for me.
Oh, okay, we don't have a chat. Okay, sorry about that, y'all. Put it in the Q&A if you have thoughts on what these identities have in common.
But Dr. Ward, I do see one person said they are all positions of privilege.
Absolutely. Yes, indeed. And the reason why these are identities that are privileged is because these are the identities that society was designed for, right? If you think about it, you don't have to think about being heterosexual. you're not daily inundated with reminders about being heterosexual, right? If you're not heterosexual, you're daily reminded, right? You don't have to think about being white. You don't have to think about the fact that you speak English. Whenever you don't have to think about that day in and day out, it's because now it's a privilege, it's a luxury, right? Society is easy to access, and all of its institutions literally were designed with you in mind. So yes, you do have that privilege. And therefore, we call these identities socially advantaged. And the identities that you don't see here are the ones that are socially disadvantaged, the ones that are pushed to the margins, because these are the ones that are centered, right? And so, these literally become the default for humanity. So when we think about standardized patients, it's these, these are the identities. When we think about, policies and practices, they are designed with these identities in mind. So that is why we still see a wide range of disparities, because again, those are groups that are afterthoughts, right? They really weren't the values, the interests, the experiences of those groups were not considered. And I think that's really important as for those of us who, care about socially disadvantaged and marginalized populations. So that's why when we talk about diversity look, I know in the, social political moment right now, conversations, legislation, funding, research related to diversity, equity, inclusion, and justice have been federally banned, meaning if you're doing that work, you have federal funds or you had federal funds, they likely have been rescinded, or you have to change, the language of what you're doing to be aligned to the administration. But this is the thing: when you have values for diversity, those values don't dissipate because the administration says that we're moving a different direction. So this is why when there's calls for diversity, and for those of us who have those convictions and we say we want to achieve health equity, then you obviously will have value for diversity. And we're not talking about the Webster definition like any difference, absolutely not. We're talking about representational diversity. We're talking about diversity in social identities, the very identities that we were talking about before, making sure that we have that representation, which is why before this administration, we used to have pipeline programs and initiatives to attempt to address that historical exclusion in, again, medicine, science, right? A range of fields, engineering. And so you have programs like, for instance, this NIH program that recognize, wow, there has been, systemic exclusion, over time. So it's not that, oh, there's not an interest, or, oh, there's not merit. It's just there have been barricade and barriers, time and time again. So we really need to create pathways so that, those who have been marginalized and excluded have an opportunity to be engaged and, and basically pursue those same opportunities. So this is the thing, right? When you see, conversations on diversity in classrooms, there sometimes is a tendency to describe it as cultural competence. I don't know if you can see me, but I'm doing air quotes. And I'm saying competence in quotes because if you think about it, it's not really possible to be competent in culture because culture is not static. Culture is ever changing. Culture is dynamic. Culture is multifaceted and nuanced. And so when we attempt to be competent in culture, there's it's kind of like you'll find textbook discussions like this one, right? Where it's kind of like, okay, look, this is all you need to know about cultural differences. And it really flattens the wide ranging experiences of people who are not white. Speaking of not being white, what do you notice? Like, why are white people not listed in this textbook? By the way, this is a screenshot of a textbook that was published, that was available, widely available by Pearson. I know y'all familiar with Pearson, right? They're a major publishing company. They publish textbooks and standardized tests and all the things. So they have to go through rigorous scientific review to get published. But this is a textbook, a nursing textbook that was out on the shelves, out, available online to and they literally, this was the way that they talked about diversity and culture. Why do you suppose that white people were not listed here? Who wants to add to the Q&A or unmute yourself and share why you think that's the case? Any takers?
Someone dropped in the chat, Dr. Ward, it's the default.
Absolutely. We don't need to know anything about white people because white people are the standard patient. We know about white people because when we talk about patients, that's what we've been talking about. We're trying to understand your difference, other, right? So now, again, remember how we talked about white, man, right? All the different, again, default identities. So when you're not listed amongst the standardized identities, we're trying to understand what makes you different. What is it that we need to understand about your cultural reference? So the thing is that when you attempt to understand differences in the ways that you see here, it is basically reinforcing stereotypes because let's be very clear. Just look at the categorizations, right? Arabs slash Muslims. We do know that you can be Muslim and not be Arab, right? You can be black, for example, and actually practice, Islam. So like obviously just the categorizations in and of themselves are erroneous. So there's that. And this is what we're saying, this is what I'm saying when I say that when you attempt to package culture in ways that are very deflating and of course rigid and stereotypical, then we wonder why does those biases show up in clinical practice, right? It's because literally we're drip fed messages, right? Not just in the media but also in the media, but also in our own health professions training programs, right? We're literally part of the curriculum where we get these messages and then we wonder why does that come up in what we describe as pain bias, right? And so we have to be very, clear that when we talk about disparities, we have to be critical purveyors of the curriculum and the evidence base because bias and a range of isms, right? Whether we're talking about heterosexism, ableism, racism, literally has been codified in science and in research. And so, that's where it takes us to be able to tease that out and recognize it as such. And yes, at the bottom of this page, you'll actually see citations because I'm making the point that literally the literature is ripe with, again, scientific and medical racism. So we just have to be aware of that. So this is why we have efforts like, and by the way, this textbook has since been pulled off the shelves and Pearson has issued a public apology. But again, this is why diversity is not enough and we have to have inclusion. So just in case you were wondering, when people say diversity, equity, inclusion, justice, the reason why those values hang together is because one is not enough to ensure that you really undo historical marginalization and historical harm. So for example, you have the diverse range of differences, but if there is not a sense of inclusion, meaning, changing power dynamics and ensuring that there is a sense of safety and welcome and validating those differences, then you defeat the whole purpose of actually having diverse, people on your research team, in your clinical practice, in your classroom, basically on your evaluation team, no matter what, the kind of outcome, you want to ensure that there are practices in place to make sure that you're recognizing and valuing and celebrating those differences. And this is just an example of, okay, we say we value, diversity. So these are some ways that we can ensure that we have that inclusion in our research. We can engage communities in the research. We can manage those team dynamics. We can collaborate, right? So this is just an example. But again, diversity and inclusion are not enough if you don't address ongoing barriers. Because we recognize that there are so many barriers that impede that inclusion, right? And therefore undermine diversity. So I'm sure many of you have seen this graphic, right, around the differences between equity and equality. And I would say on the surface, this graphic does the one job, and that is literally just giving you the semantic difference between equity and equality, with equality being sameness and equity being fairness. Now, I will say, and my students know, I absolutely despise this graphic. And I know so many people use this graphic to understand the difference, but what this graphic does not do well, let's go back to the opening poll, right? the concept of equity has been vilified. The concept of equity feels oppressive to people. So just to saying, oh, but you got to give people what they need, that doesn't resonate with a large portion of people, and so people won't be in support of anything that is equity focused and equity oriented by just saying we're going to focus on fairness, right? People like kind of poke holes in that. And this is why, because look at the way we actually present equity. We present equity as taking something from someone else. And that's often why people think it's oppressive. But you took something away from me. I'm entitled to get resources. As you can see, the first person with the, that has the arm up on the equity side, they were, given a box, but now the box was taken away from them. And I want to be very clear when we have conversations around equity, we don't need to present it as a zero sum game where some people are losing something and the other people are gaining what they lost. No, 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 right? There's more than enough resources to go around. This is not about taking from one group and giving to another. Absolutely not. So that was one of the reasons why I don't like this graphic, because it actually adds fuel to the fodder around I'm losing something when you talk about equity. So that's one of the first reasons. Secondly, what it also doesn't do is, when you look at this graphic, there's a tendency for you to, like, the unit of analysis is the people, the groups, right? So when you look at that first group, right, it basically tells a story of, this is a group that is self-sufficient. They're, inherently capable, right? Because as you can see, look, they can look over the fence. They don't have barriers. Or they don't there are barriers, for example, because you can see the fence actually is a barrier, but as you can see, the barriers don't stop them because, they naturally inherently um can make it. And so there's this narrative that gets attached to those groups that they work hard and that they naturally are, succeeding because they've worked hard. And whereas the second group is kind of like, okay, you don't naturally achieve as much as that group, but look, you still making it, right? As you can see, right? From the group in the middle. Again, the barriers there, it's kind of, you knee deep, neck deep in it, but you still have enough. Whereas that last group, there's a tendency to focus on them being deficient, lazy. I mean, just think about the way the media describes the groups that need, support from the government, right? These groups get described as welfare queens and lazy and taking handouts, right? Look, we got to give all this to you. Like, why don't you just work hard for it? Pull yourself up by your bootstraps. And that's the problem with this graphic, because really we're putting the onus on the groups. We're focusing on the differences in the groups. Okay, you naturally have what it takes. You don't have it, and you need, and this group doesn't need. Why are you taking from that group? No, 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 no. We should actually be focusing on the policy, not the people. But this graphic doesn't allow for us to do that. This graphic actually does allow us to do that. What do you notice, right? Unlike the first graphic, do you see at the bottom the foundation is different? In the previous graphic, everyone is the even playing field. That is not realistic, and we know that everyone's not on the even playing field. So why would we even present that, right? So what we do need to show is that there are some groups that have, they are perpetually playing catch up, right? Again, just decades and centuries of basically false starts, and because the finish line keeps changing, right? Whereas there's other groups who have a head start. And so, as you can see at the foundation, now we're talking about structural issues, right? We're not talking about the groups themselves, because look, the groups are different. So we're not saying they're all the same. They're not the same. See, they're different colors, which represents difference. But now we're not placing a value on those difference. Like the big group, the tall group, the more sufficient group. No, no, no. It's just different. There's no value placed on the difference. It's just different. And so, as you can see, they're different groups, but one group is not better than the other. It's just different. But as you can see, since some groups have a head start, since some groups have been hoarding opportunity, since some groups are always playing catch up and never can, seem to basically address all the barriers, that is why. And again, by the way, let's be very clear. Let's not characterize these groups that are have been historically marginalized and and excluded as hopeless and powerless, because as you can see on that first graphic, you see that fence and there's like a hole in the fence. they made a way out of no way, right? And we see that because if you think about socially disadvantaged groups around the world, all social movements around the world have been led by socially marginalized groups. So we know they have power because every single social movement, from civil rights to Arab Spring to Stonewall to, Black Lives Matter. It doesn't matter what the movement is, right? We could be talking about LGBTQ rights. We could be talking about immigrant rights. No matter what the movement is, any social change movement is led by the most disenfranchised group. So we know they have power, right? As you can see, they made a way. They found they like punched their way through the barrier. But and that's the thing. The barriers are not the same. In the original graphic, it was like, we all got barriers. Okay, you're right. We do all have barriers, but who has more? The most marginalized population has more, which is why you see the rising. But it's not just a plateau across all barriers are equal. They're not equal. Actually, the most disadvantaged group has increasing barriers, more barriers than everyone else, and that is why we need to ensure that we provide the resources and actually remove the barrier actually. And so and that's what this is. This graphic is just showing, well, just give them more, but the barrier is still there. So this is why when we talk about health equity, we really should be talking about getting to the root causes and not just the band-aid approaches, like, okay, well, let's just do this extra program, let's just give this extra incentive. Actually, we need to uproot the inequity. Like we know why the people are living in poverty, why we have mass incarceration, why we're criminalizing substance use disorder. Let's just grab it by the root. And that is why the Robert Wood Johnson's graphic, it makes the most sense when we talk about equity. And this gets back to the fair opportunity to achieve your fullest health potential, which resonates with Americans. Given that poll where people say, like, when you ask them, do you agree that everyone should have a fair opportunity? People agree with that, right? And this is why, because on the left hand side, you see the most socially disadvantaged group in this graphic happens to be people with, physical disability, right? You can be visually impaired. You could, have be in a wheelchair. Okay. So that's this graphic, and be very clear that we can swap out that group and put another group, because there's only all these socially disadvantaged groups, right? We can put people that are managing substance use disorder. We can put, people that are living in poverty. We can put people who live in rural or urban underserved area. Like, again, all these disadvantaged groups, you can plug them in, but this just so happens, just to show you the graphic for the purpose of the exercise, this is the group that we're working with right now. But again, any socially disadvantaged group can be here. What's the barrier? The fact that they can't get across the street. So if you have an equity focus and an equity, you value equity, you will remove that barrier. So as you can see, the barrier was removed because you added a curb cut. So you were thinking about the most disadvantaged group. What can I do? What is the barrier that's keeping them from crossing the street? So from a city design perspective, right, it would be, you know what, we should add a curb cut here. And that way, they can get across. But this is how equity works, right? When you removed it, when you thought about the barrier for the most disadvantaged group, what you end up doing is you remove the barrier for every group. So now, not only do you, have the signals, that's why you can see like the audio of like, you can walk, right? Because they can't see. So you need to have the audio, you need to have the curb cut. Okay, but not only did you do that for that group, but you know who else actually benefited from that? The person pulling the stroller. They have to ask other people, can you grab the top, the bottom of the stroller? I get the back, and we both work it. So you had to ask for help because you couldn't do it by yourself without like plopping the baby down, right? The people pulling the luggage, had to pick up their luggage, and maybe you got two, you're struggling doing one at a time. The FedEx driver with with the dolly. There was all these other groups that we hadn't thought of because they're not the most disadvantaged, but there is a disadvantage because they still had to figure out a way. Remember how we talked about like making a way out of no way? Those groups were struggling because it was a barrier, but there's so many groups that are now benefiting because you made the curb cut, aka you removed the barrier. So again, this is a city design perspective, but imagine applying this to health systems, education systems, right? It could be any institution. Think of the most disadvantaged group. What are the barriers for them? When you remove that, everyone is benefiting. Let's go back to that definition. Everyone has a fair opportunity to achieve their fullest health potential. That is what equity is. And everyone wins when we invest in equity. So this is why, again, when we say diversity, equity, inclusion, we have to also include justice, because we know there's so many forms of justice, by the way. And oftentimes we think of, do no harm, and that is, important. But we also have to think about the harm that has already been done historically, which is why oftentimes when you come to equity talks, you'll often see someone start off with a land acknowledgement, recognizing the harms of the past. We're all literally, impacted by settler colonialism, right? The fact that we're sitting on sowing, we're basically all occupying and training on and living on and playing on land that was, the first lands of indigenous people, right? Who sold into that land and were forcibly removed from that land. And we know data shows us that there are repercussions, right? When you, like from that colonial act that still reverberate today, right? If you look at data and you pull up data for Native Americans in this country, you'll see time and time again that they have, disparate outcomes when it comes to their life expectancy, when it comes to substance use disorder, when it comes to diabetes and other chronic conditions, suicide ideation. And that literally can be tied to the historical trauma and attempt at cultural erasure, which, by the way, is happening right now in this social political moment, right? Um, when we think about the attempt at erasure of people that are gender non-conforming, that are, undocumented, things like that. So again, that's literally when we say justice, it's both harms of the past and even contemporary harms right now. So this is why those values hang together and we have to address them as such. So you're probably like, wait, we just get into the objectives? Yeah, that was a warm up. Okay, that was the primer for what we really are going to get in today. So I got 30 minutes to get to what we're going to really get in today. And that's basically distinguishing between when we say health equity and health inequity and health disparities, these are not synonyms. So let's be very clear what we're talking about. And then recognizing that justice is the tool to achieve health equity. And ultimately, we can't do that without really understanding the determinants of health. How they're both social and structural in nature. So I know that, here you are, public health students, public health practitioners. So, of course you know what health is, right? But I want to remind us why it's so important for us to rely on the World Health Organization's definition. Even though, yes, the US has since pulled out of the World Health Organization, I'm still relying on the definition that they offer because it's the most comprehensive. Health is not just physical. It's not just do you have a disease or not, right? It's definitely, COVID reminded us there's a social element to health, right? And that impacts your emotional and your mental health because all of that is, part of our health. So, and when we talk about health, we know that there's a tendency, to only focus on our individual health, like our health as a patient. But if we go to the public, health, aspect of things, we know that now we've moved our unit of analysis from individual people and individual patients to the health of entire communities. And that health literally relies on research, education and outreach and policy, and it has to literally happen in tandem. And so, we have to have research. Everything needs to be evidence informed. As we know, public health relies on science. Right? We believe in science, right? And so that science informs practice, aka policy, and then that policy needs to be, widespread and shared so that people, know. So whether we're talking about seatbelt use or we're talking about vaccines, it starts with research, right? Then you make it a policy or practice, right? Oh, you know what? This vaccine is required so that you can go to school, or this vaccine is required to go to work. Think about COVID. Think about all the vaccines you need for school, right? So we've done that, and then you have to do the outreach and the education so the general public knows, like, they can make an informed decision. And so that's how public health works. And we can see, now that we're no longer wearing masks and we're no longer, socially distanced and sheltering in place because a good portion of the population got vaccinated, right? That's how herd immunity works. So oftentimes, again, and I love this pyramid because it really hones in on why, the perspective when it comes to achieving health equity, we really have to be justice oriented. When we think of like educating individual people, right? Okay, you need to, move more, eat that, stop doing this, use a condom, right? And again, that's helpful, but that's individual patient, right? Counseling and education. And there's a role for that. I mean, so I'm not suggesting do away with individual patient counseling. Absolutely not. We need that. What we're saying is if we really want to have an impact on population health, right? Like the health of communities and the populations that live in them, We're not talking about individual, education. We're talking about actually changing social attitudes and, the way people like generational attitudes and belief systems, because that is going to impact policy, right? So that is why when we talk about population health, we're not just talking about public health, we're talking about the individual groups. So these are actually the groups. These, remember how earlier I was talking about, oh, the health goals were to eliminate health disparities and then achieve health equity. So health disparities only exist in socially disadvantaged populations. These are the populations that experience health disparities. And so I've actually taken the liberty of color coding this to indicate to you that health disparities are not a coincidence. They're not happenstance. They're very much patterned. And they're so patterned that I literally could color code this and tell you what they have in common, right? Which means that they're structurally engineered. They're social. There's no biological explanation for these unfair, unnatural health outcomes. They're 100% due to social and economic reasons. So, if you look at all of the groups that are in red, those who are children, minors, elderly, malnourished, immunocompromised, not health literate, the one factor that, they all have in common that is a source of social disadvantage is that they are dependents. There's someone else making decisions on their behalf. What you gonna eat, if you're going to go see a doctor, if you're going where you go to school, where you going to live, and that matters because we know the social determinants, housing, neighborhood, and built environment, all of those literally determine your health outcomes, your life expectancy, right? Your zip code matters. So when someone's making all those decisions on your behalf, that is a source of, vulnerability, aka disadvantage. And then if we move to the green, those who are mentally unstable, system involved, you probably like system, like what systems? Well, you can be in the foster care system, you can be in the criminal legal system, right? These are some systems. And then you could be managing substance use disorder. So no matter which group, all of them face stigma. And that stigma literally follows you. Just imagine the person who, yes, you committed a crime, you were convicted of a crime, you've done your time, now you're a returning citizen, and that is following you. So now you can't get a job and so you find yourself in generational poverty, you and your family, right? Because of the stigma of you being system involved. So that's just one example of there's so many. But that's a form of disadvantage. And we see that when people are, a part of those groups, their health outcomes are worse than those who are not, don't have the stigma because of their involvement in these systems. Then let's go to the purple. You can be insured or underinsured because you can have insurance, but it doesn't cover what you need. So you can be underinsured, be in poverty, have a disability, or be differently abled. You could be experiencing homelessness. And each of these groups are experiencing disenfranchisement, right? I know oftentimes when we think of disenfranchisement, we only think about voting, but we often use voting as a way to talk about there's an attempt at your power because voting is political power, right? But then there's also, again, like we talked about earlier, none of these groups are powerless, right? But there's an attempt to, you know, salvage, basically deprive you of your power, in because you're part of these groups, right? And let's be very clear, you can be someone that is high income and have a disability, but because you have the disability, that's the form of disadvantage. You're privileged in that you have, high income, right? And you're educated, and you have this disability. So that's where you receive the social disadvantage and the discrimination because of that part, right? So recognizing that sometimes that's the thing about, our identities, right? How intersectional they are. You can have some disadvantaged identities, right? Targeted identities, and then you have some privileged identities and some form, like we call those dominant identities. And you have both. And just imagine if you have multiple disadvantaged identities, like what that means when that disadvantage compounds. Like this blue group, right? People who are minoritized, racially, ethnically, gender, sexually. You're a refugee or asylum seeker, you're undocumented, you live in underserved rural or urban area, and you can't read, write, or speak English. Again, society literally was not designed with you in mind. These groups are often afterthoughts in policy, right? In practice. And so their needs are often overlooked and not met. And that's very well documented in the literature. So you're probably wondering, okay, we just went over socially disadvantaged groups. Why would we single those groups out. If we say we want health equity, shouldn't we be focusing on all groups? Okay. The reason why we want to hone in on the most socially disadvantaged group is because when you say all, that's basically a synonym for the advantage group. Because again, the default will be advantaged. And then therefore you're actually maintaining the gaps, if not even worsening them, which is why you want to hone in on the most disadvantaged group, like we talked about in the graphic, because now you remove the barrier and now everybody actually wins. So earlier I mentioned how I had published this article on how we just don't even talk about health equity and health disparities the same. So, for example, here in the US, when we talk about disparity, we have a tendency to only focus on racial differences and racial ethnic groups in the US just because of, how racism is like basically in the fabric of this country. So, of course, many of the differences, the unfair outcomes that we see are racialized. Whereas elsewhere in the world, they don't even use the term health disparities. They say health inequalities, and they're focusing on class differences or geographic differences. Right here in the United States, the Institute of Medicine, which is now the National Academy of Sciences, their definition of health disparities are really focusing on healthcare differences, which is why they saw those racialized differences and they came out with this landmark report called Unequal Treatment. And so the NIH, was like, you know what, you're onto something. So they actually do use that definition under healthcare disparities. But then they actually rely on the way that the CDC thinks about differences and incidence and prevalence, right? But then they also up the ante and they start to think about quality of life. And they talk about health status disparities. Right here where I live in DC, we have an Office of Health Equity. And in that office, they define disparities as, anything related to, disadvantage, like I talked about earlier. And they list all the forms of disadvantage. But I like the World Health Organization. I'm telling you, they got some good definitions. They're just nice and, succinct and to the point, right? Because again, you can say, oh, but I want to use the NIH definition. I want to use the National Academy's definition. Feel free. But let me tell you why the World Health Organization definition resonates, because it's just like literally, it takes all those definitions and makes it very clear in one sentence. When we talk about health disparities, we're talking about differences in health that are unnatural, unnecessary, unfair, and unjust. Point blank and period, right? And so, I think it's really important for us to think that through, because when we say health disparity, we're not talking about naturally occurring differences. So, for example, in this quiz, right? When I'm asking you, okay, I just talked about, what a health disparity is. I want y'all to put A, B, or C into the Q&A box. If you think that a person who has a rare blood disease that becomes chronically sick and at risk of premature death due to unavailable treatment modalities is actually an example of a health disparity. So go ahead and put A if you think that's one. Go ahead and put B if you think it's Black women dying of breast cancer despite having a lower number of cases, a lower number of new cases than white women who survived breast cancer. Go ahead and put B. And then C, higher level of long bone fractures among skiers in comparison to non-skiers. All right. So Cassie, are there any A, B's, or C's in the Q&A?
No, ma'am, but they are dropping it in the chat.
Oh, you put it into the chat. Perfect. Okay, so the chat works now. Love it. Okay. Okay. So let's go ahead and go through the answers, shall we? So let's just say a person. Let's stop there. Can people have health disparities? Like, can I have a health disparity? Can you have a health disparity? No. Health disparity is a population health metric. Let's be very clear. Okay. So actually, that was the first indication that A is wrong, because health disparities don't exist in individual people. Okay. So let's move on, because there's more reasons why A is not right. So A is wrong because it's not a person can have a health disparity, but then also it says they have a rare blood disease. Again, a health disparity is unnatural, unfair, and 100% tied to social explanations, right? A rare blood disease is a naturally occurring health difference. There are naturally occurring health differences. Y'all know this, right? Right? Neurodiversity is a naturally occurring health difference, which is a biological explanation. Genetic disorders, chromosomal abnormality, all the things, right? Anything that is biologically explained, those are not health disparities. Those are naturally occurring health differences. So when you say a rare blood disease, naturally occurring. Okay, so those are two reasons why A is incorrect. Now, I realize why some of you may have chose A. You may be like, wait, but what about the fact that they're, having premature death because the treatment is unavailable? The treatment is unavailable because they got a rare blood disease. It's rare. So that has nothing to do with unjust and like we never seen this before. So you can't, and even if you did come up with something, you're just addressing this for a biological, people who have this rare blood disease. So you're not addressing socially disadvantaged populations. So that's why A is wrong, wrong, wrong. B, Black women dying of breast cancer despite having a lower number of new cases than white women. Okay, actually, let's pull in, I'm gonna basically, throw a curveball for you with adding some biology to this one. Did you know that white women actually do have a BRCA gene, meaning they actually are biologically susceptible to having breast cancer, which is why the epidemiology shows us that white women actually have the highest number of cases of breast cancer because they do have a biological predisposition to it because of the BRCA gene. So we have biology there, right? So that's a naturally occurring, difference. What makes this a health disparity is because white women, even though they have this genetic, biological predisposition to have it, they have the highest survival rates. So somebody who has a genetic predisposition can survive it. That means that everybody should be able to survive it. So why are Black women who do not have a genetic predisposition have one of the lowest numbers of new cases, but they're more likely to die from it, which means they have highest mortality even though they have the lowest number of incidents? There's no other explanation for that other than a social reason, right? There's no biological reason for why they're dying more than someone who has a genetic predisposition. So the social explanation is that they're not being screened, right? White women get early detection, aka they're the standardized patient, remember? So all of their PCPs are like making sure, okay, get, early detection, mammograms and self breast exams and all the things. But Black women are not getting that. So by the time they find out they have, breast cancer, their breast cancer is already in a later stage. It's already aggressive. It's already metastasized. It's already spread. But that was preventable. That was not like that there was no reason to do that because you can literally see that we have a model for how all women patients should be able to have early detection. So this is a glaring example of a disparity, right? 100% social disadvantage. And then finally, higher rates of long bone fractures among skiers in comparison to non-skiers. So remember, who experiences health disparities? Socially disadvantaged populations. There is no socially disadvantaged group in this example, right? We have two groups, but you're not talking about socially disadvantaged groups, actually. If anything, we're talking about advantage groups. So skiing is a very high income sport, actually. And so that's actually naturally, occurring. Like you're just more likely to get a long bone fracture by the fact that you're skiing. So we're not talking about something that's unfair, unjust amongst socially disadvantaged groups. So I want to be very clear, on what a health disparity is and who experiences health disparities. So now let's put it all together, okay? So when we talk about health disparities, make very clear that only socially disadvantaged populations can even experience it, but the only thing we're actually measuring is the actual outcome itself, right? Incidence, prevalence, like we just know what they have. It's basically just an empirical measure. That is it. We don't know why. So what explains why is health inequity, okay? Health disparity is, okay, high rates of cancer, diabetes, HPV, like whatever, you fill in the outcome, right? You can see the disproportionate burden in that group, the socially disadvantaged group. And remember, social disadvantaged group are not just Black people, right? Remember that we show it could be children, it could be people living in poverty, it could be people that live in rural areas. So white people can have health disparities too if they're part of socially disadvantaged populations that we just covered. Let's be very clear. Health inequity is why they have those disparities. It's because of large macro issues like poverty, like racism, like gender oppression, like heterosexism, like patriarchy, right? That actually addresses maldistribution of resources and discrimination, right? That is why redlining, right? That is why you see the disparities that you have, the inequity. So how do you address the inequity so you can address the health disparity? Through social justice. Social justice is the how, okay? So we went from the what, health disparity, to the why, health inequity, to the how, justice, right? Literally changing, addressing those harms and attempting to repair the damage that's been done so that ultimately we can reach the goal, health equity. Remember, everyone can have a fair and just opportunity to achieve what is biologically possible for you. Okay. And so that means there's no social reasons for you not to to be where you need to be, right? And again, everybody has a different level of being, right? Based on your biology, right? My bone density as an 8-year-old versus an 80-year-old is gonna be different, right? Because of development, right? So what is biologically possible for you, you should be able to achieve that. There's no social reason why you can't achieve it. That's what health equity is. And this is where those determinants come in, right? Because when we say our health status and our life expectancy and our mortality and our morbidity, all of those are literally determined by where do we live and do we have health care? Do we have food? Do we have economic stability? So that's where all of these determinants come in. And just so you know, I know oftentimes there's a tendency to put all of our eggs in the healthcare basket. Like, okay, all we got to do is make sure people got access to healthcare. Actually, 20% of our healthcare outcomes is healthcare. The other 80% is everything else because the average person doesn't live in a hospital or a clinic, right? So you got to make sure people have housing. You got to people adequate safe housing, adequate safe food, quality education, right? So we really need to spread out and actually, focus on a wide range of things, which is why it's so great that clinicians now can bill for the time that they spend talking to their patients about the social determinants. That's what those ICD-10 codes to the point where they have this national program called Park RX, right? Park prescriptions. Going back to how our health is so much more than physical. So literally, clinicians are actually prescribing parks, and there's a whole literature talking about how being out in green spaces not only is physically helps with oxygenation, but also mentally and emotionally and socially. You're more likely to be active. You're more likely to be with somebody, or like a dog, or a friend, or bird watching, or basically it brings solace and peace of mind, and literally all of the things are really the all the elements of health are really being restored. And so I think that oftentimes when we talk about health disparities, there's a tendency to focus on lack and gap and need. But let's please recognize that communities that, where these populations live have many strengths, have many assets. So we need to be engaged in appreciative inquiry as well. And I want to give an example, a local example, since I do live in DC. Um, like many places throughout the United States that's facing food insecurity, again, we tapped into one of, our local community assets. So on the left-hand side, this is a map of DC, and what you see, the circles is basically the radius. When we talk about food deserts, right? The grocery store and that radius, like around it, is kind of like how far or close you live to the grocery store. So like if you're not in that bubble, you're in a desert, right? So there's lots of food deserts throughout the city. And then we recognize, okay, what can we do from an asset-based community development framework to tap into some of the local community assets? Well, you know what? The community, I mean, the local corner store is an asset because it's a brick and mortar building. We have so many of them. So if you look on the right hand side, you would literally see the little yellow dots that represents the corner stores, and how those the owners of the corner stores teamed up with farmers markets and DC Central Kitchen, and just Capital Area Food Bank, and other kind of vendors of fresh produce. And now they've outfitted them to be healthy corner stores. So this is an example of how you can address a glaring, inequity in, one of the social determinants. And you can do that by tapping into local assets in your community. But we know there's so many ongoing challenges, from, medical mistrust, disparities, historical trauma, right? And the APHA, the American Public Health Association, AMA, the American Medical Association, they recognize racism as a threat to public health. And then, and we just, came off of the end of National Public Health Week. So there's many ways that we can address that. One of those ways is to address race-based medicine, stop treating race as a biological determinant of health. That literally has come through in the way we think about, basically has facilitated maintaining disparities in kidney disease, right? Because literally we arbitrarily change the threshold. We arbitrarily assign a number, right, based on you having a black kidney, which by the way doesn't exist because there's no such thing as a black kidney. Race is actually not biological, right? Ever since we completed the Human Genome Project, we looked through the entire body and race there's no molecule, there's no DNA, there's no chromosome, there's nothing that indicates your race because race is made up. So race is a social and political construct. And so we have the evidence for that, but medicine has not caught up and is still using 40 different race-based procedures, protocols, algorithms, with this being one of them, the EGFR, and that maintains disparities in kidney disease because you're treating somebody for their black kidney that doesn't exist and you're arbitrarily assigning a number and now they're not meeting the threshold to be eligible for a kidney transplant. So the National Kidney Foundation has come out and said, stop treating race as, it's biological. And so the great news is that, clinical practice across the country has now dropped that. And now, so that's one clap, right? Great. But we still got 39 other algorithms, clinical protocols, and practices that are still race-based. So we do have our work cut out for us. And that's why right here in the School of Medicine and Health Sciences, we have a curriculum committee that talks about disentangling race from ancestry and treating race in the social history and ancestry and genetics and the medical history, and doing that in the training of medical professionals so that when they get into medical practice, they also will, not practice race-based medicine. So ultimately, health equity is definitely achieved when everyone has this fair opportunity to achieve their full health potential. And remember, the only way to do that is through a justice lens, basically restoring human rights. But that means that we have to address systemic social inequities. And that way we can be, culturally responsive and structurally competent to eliminate disparities amongst the most socially disadvantaged groups. So feel free to keep in contact with me. I will PDF these slides and make them available to anyone who's interested. And with that, I'm ready to take any questions you may have.
Thank you so much, Dr. Ward, for that lovely public health discovery seminar series. So at this time, feel free to drop your questions in the chat or in the Q&A. And yeah,
I we only got 2 minutes. Who got a question?
thank you, Nicole. Dr. Ward, she said, great presentation, very informative.
Oh, well, thank you. Appreciate you being here. When I was logged in, I couldn't see the chat. So I see most of you selected B. Yes. You can recognize the health disparity. I love it.
Jay Williams said, thanks, no questions. I enjoyed the presentation. I'm also interested in a PDF version of the slides.
Absolutely. I'll make that available to Kathy.
All right. Oh, okay. Let's see. We got something in the Q&A chat. Amazing. Thank you for being here.
Oh, I appreciate the love. I'm glad to see so many of my students here. I'm looking through the attendee list. Love it, love it, love it.
All righty. Well, if we don't have any more questions, yes, we will make access to those slides. And so when Dr. Ward sends me that PDF, I will go I'm gonna go and write now your all's names right now so that I'll know that you want to get those slides. But yeah,
Was today's presentation recorded? Is it
it
recorded
is.
sent out?
It
Okay.
is.
Okay.
So yes, the presentation will be it is recorded. And Dr. Ward, real quick, if you could drop your contact information in the chat. A lot of
Wait, how do
people.
I access the chat? I only have the one that says host and panelist.
Oh no, you should be able to say click on the arrow and it should say to everyone.
Okay, okay, I got it. Perfect. Okay, here it is, y'all. Here's my email.
But yes,
Okay.
this seminar series will be available on our YouTube playlist. And so definitely you can always go back and look at Dr. Ward's presentation as well as If you want to share with other people, you could definitely do that. But again, thank you all so much for joining today's Public Health Discovery Seminar Series. Thank you so much, Dr. Ward, for being here. And you all have a wonderful Wednesday.
Okay, you do the same. Thank you. Bye. Thanks for
Bye.
tuning in.